From the Yale Center for Faith and Culture, this is For the Life of the World, a podcast about seeking and living a life worthy of our humanity.
Hi friends, I'm Evan Rosa, and this is a bonus clip from episode 232 of For the Life of the World, a conversation that Macie Bridge had with physician and medical ethicist Lydia Dugdale. It's called Dying Alone, Terminal Loneliness, Modern Medicine, and Contemplative Solitude. It came from our Solo series. Lydia wonders, why don't more doctors talk about death? She started asking that as a medical student, and what she discovered was the ars moriendi, the medieval art of dying. It was a genre widely popular in the West for more than 500 years. It was adapted by both religious and non-religious traditions. It was even illustrated quite often for the illiterate, using skulls. But this is the central claim. Dying is part of living. If you want to die well, you have to live well. And for Lydia, living well means cultivating virtue, hope, patience, and joy, cultivating community while we can. She ends with a story about a grumpy old man who spent 20 years in the hospital, most physicians and nurses avoiding him, until, as he reports, someone finally saw him. Thanks for listening. Here's Lydia Dugdale.
I started noticing as a medical student, I'm thinking, who is actually having frank conversations with these people about what's going on? Why are doctors not talking about death? There's the kind of emergence of palliative care as a discipline in medicine. And what that did on the one hand is it gave us great resources for helping to attend to the symptoms, the uncomfortable symptoms of being sick and even dying. The problem is that a lot of physicians started outsourcing their comfort in talking about death to the specialists. So I would say that most medical professionals today are very unpracticed at talking to patients about their mortality, even though we are really the intermediaries between life and death. I'm not saying we're priests, but that used to be the role of the priest. And so it is now the role of the physician, arguably the nurse, who is the one who's actually at the bedside much more than the doctor. But the doctor is the one calling the shots on treatments and maintaining the machines, et cetera. I was very perplexed about why doctors don't talk about death. And then I started realizing, doctors themselves are afraid to talk about death. Not only are they not practiced, they themselves have not thought through their existential questions. They have their own death anxiety. I had one colleague say to me, I don't know why you're interested in death. She said, I myself am so afraid to die. I would never tell a patient that a patient's dying. I just don't want to talk about it. So, right, which seems like an abdication of responsibility, but there you have it. And so I started digging into how in other times and places, people have addressed the questions of mortality. And in my digging, I came across the ars moriendi, which is this medieval genre of literature on the preparation for death. And I started wondering whether we could revive some version of the ars moriendi. And, the ars moriendi, this art of dying, it ended up being wildly popular in the West for more than 500 years. Lots of different religious and non-religious traditions adopted it, adapted it, wrote their own versions of it. There were illustrated versions for the illiterate. And I thought, well, look, if it can be adapted by all these different religious and non-religious groups, why couldn't it work today? And so that was some of my work, I guess, over the last 15 years in a couple of different books to try to think about reimagining the ars moriendi today. But of course, central to this genre of literature over the whole 500 years is that if you want to die well, you have to live well. Part of living well meant cultivating virtue, right? So if you don't want to die an impatient, bitter, despairing old fool, then you need to practice hope and patience and joy, right? You need to cultivate the opposite of that. But the other part, besides becoming a character of virtue or cultivating a life of virtue to live well, to die well, is that we live best in community. If living well is very much tied to dying, then if we want to die, we also have to be cultivating that community while we can. And this is something I've seen in the hospital, right? So the unrepresented patients, they ultimately are dying alone. I mean, just to illustrate this, you write a book and you never really know what it'll do. But I do remember being contacted by a guy who read it. He was in good health, but older, and had been estranged from his adult children for years. And he said, I read your book and I want my kids there when I die. I don't know when I'm going to die, but I've committed to investing in relationships with my adult children in ways that I haven't for decades. And he now gets together with them multiple times a year. They have dedicated family time. And for him, it's been so life-giving. But it was this nudge of thinking about loneliness in the context of mortality. If you want to die well, you have to live well. And that requires deep investment in community and relationship. And relationship does not just happen. It's a work in progress, and it has its ups and downs, and we just keep working at it, and we mess up and ask for forgiveness, and people will hurt us and we forgive them. And this is the sort of iron sharpening iron of life and community. But we have to be all in, or we end up like all of these patients here in New York City who have no one that I can reach out to as they're dying. I took care of a patient for many years. He was constantly hospitalized at Yale New Haven Hospital. And he was a miserable person. He was absolutely a miserable person. And everybody knew him because he was always in the hospital. And everyone hoped that he would not be assigned to their team to have to take care of. And he was assigned to me one of my last times I was working at Yale New Haven Hospital. And I thought, I'm going to model for my young doctors here how to care for a very difficult patient. And he ended up so completely destroying me verbally that I had no energy left I was beet red and so embarrassed and humiliated. I just took my little team and we left. And then shortly thereafter, we were checking on him a day or two later, and he basically said, sit down, I need to talk to you. And we sat down, and he just started telling us his story. And I was so moved by hearing this man talk about how his chronic disease took everything away from him, his church, his family, his community, his profession, everything. He was always hospitalized. I wrote a piece about him for a medical journal, little medical humanities thing. And I knew that if I wrote about him, I had to go share it with him. But he was such a nasty man that I was just praying that he'd be asleep or be at a procedure or something. But I knew I had to share it with him. But I went and he was asleep, and I was so happy. I was trying to sneak away. And then his nurse caught me. She said, did you want to see him? And I said, I did, but it's okay. She said, no, he's in a good mood today. You should just go in and wake him up. And I'm like, oh man, go in and wake him up. He's not going to be in a good mood. Anyway, I went in and I read this piece to him that I wrote about him. And he started weeping. And he said, someone finally saw me. Someone finally saw me. I've been in this hospital for 20 years and I didn't think anyone ever saw me. And I think that's the message on loneliness, which is that we are in a world where sometimes it's we ourselves, sometimes it's the neighbor next door, sometimes it's a colleague at work or the checkout person at the grocery store. How can we see each other and connect in a meaningful way where people feel seen? And not a superficial sort of seeing, but seeing in a way that touches hearts and transforms lives. And so I think that's the challenge. Again, none of us does it perfectly, but I think that we can aspire to do it better. And the more we practice, the better we get. And the more we practice, the more other people will engage in that sort of outreach, if you will. And I think it will help to mend some wounds in this very broken world.
This episode featured Lydia Dugdale from a conversation with Macie Bridge. Noah Sentil is our production assistant, and he edited this episode. I'm Evan Rosa, and I produce the show.
production of the Yale Center for Faith and Culture at Yale Divinity School. For more information, visit us online at faith.yale.edu and lifeworthliving.yale.edu, where you can find a variety of educational resources, including podcasts, videos, books, and more, all to help people envision and pursue lives worthy of our humanity. To get in touch with us, you can email faith@yale.edu, share guest ideas, feedback, concerns, questions, criticism. It's all welcome. If you're a new listener, we're glad you're here. Remember to hit subscribe in your favorite podcast app so you don't miss the next episode. And if you've been listening for a while and you want to support the show, here are just a few meaningful ways to do that. You could share one of your favorite episodes, maybe it's this one, in your next conversation with your family, your friends, or online. You can give us a rating or a review in Apple or Spotify. Or you can go one step further with us and become a supporter of the Yale Center for Faith and Culture. Everything we do, including this podcast, works on the generosity and partnership and friendship of people like you. So if you're interested in making a gift that's within your means, visit faith.yale.edu/give. Thanks for listening, friends. We'll be back with more soon.